We are live now.
Okay. So over to Dr. Shwetal now.
Hello. Good afternoon to one and all who are present here. I am Dr. Shwetal Sangvi, Senior Medical Director from Insignia Communications. And on behalf of Dr. Reddy's Laboratory, I'm pleased to share this e-based platform here with you all. As clinical practitioners, we always come across n number of patients with pain. And pain as such known to us is a chronic disabling conditions. And we are always trying to find pain relief measures to give a better quality of life to our patients. This continuous and enduring efforts by Dr. Reddy's Laboratory has brought us all together for this webinar on the novel alternatives for pain management. On this webinar with me, I have Dr. Ram Prabhu, the renowned orthopedic surgeon from Mumbai, who practices here in Mumbai itself. Sir is alumni of St. G.S. Medical College and KEM Hospital. He is past president, Indian Orthopedic Association and Mumbai Orthopedic Association. Sir has just finished his tenure from APO as vice president. Sir, it is indeed a pleasure to have with you, and I will be delighted to hear from you. Over to you, sir.
Yeah, so thank you very much, Shwetal, for the kind introduction. Welcome to everybody, including the professor from Germany. Now she is in Switzerland. Professor Dr. Sigrun, who is going to enlighten us with wonderful alternative therapy for pain management, especially the chronic management of pain. As all of us know, the pain is really disabling, and it really is a great disability causing to everybody, all the people. And Professor Sigrun, let me introduce her and her biodata. She is a specialist in general medicine with additional qualification as neuropathic treatment and spatial pain therapy. She heads the research focus on herbal drugs at the Institute of Forensic Medicine at the University of Freiburg, with lecturership at Sydney University in Australia and Hebrew University in Israel. She has tremendous experience in managing pain, and she has published more than 100 articles in the recognized journals, and she has actually contributed by writing 5 books. I'm really happy that such an eminent personality is here with us to speak on the pain management, and I think it's going to give a lot of insights, not only into the pain management, but also alternative therapy, which she has been researching for such a long time. And I'm really glad, and I welcome her for this international webinar, which I think more than 1,500 people have already registered and will be logging in. Thank you very much, Professor Dr. Sigrun Hausmann, for your kind coming on this webinar. Okay. Can I have the slide share, please? Next, please. Next. So let me talk to you regarding the pain, which is a disabling phenomenon. And it is the pain which really gets the patient to the doctors. And we try all sorts of different modalities, not only the analgesics, anti-inflammatory, NSAIDs, etc. But at the same time, there are various other alternative modalities that we try, like exercises, physiotherapy, some kind of ultrasonic, and some other therapies also. So amongst Indians, chronic, moderate, and chronic severe pain were 37% and 63% respectively. And that is a huge burden on the society as such. And that leads to poor quality of life. And that all of us know we can really not function. We cannot function properly. They are not able to exercise, sleep, maintain relationships with the friends and family, and maintain an independent lifestyle. And this is what is really something which worries the patients, which really gets them to the doctor so that they can get rid of this pain. And this pain is ultimately acute pain, where they need to rush to the hospital immediately, something like what people have, acute renal colic, or some shoulder problem, rotator cuff injury, or bicipital tendinitis. even some other musculoskeletal problems can drive these patients to the hospital, and doctors are there to help them. They're obligated to help them, and of course they get this treatment treated immediately. Next, please. So the first and foremost, whether in parental form or whether it is oral form, use of analgesics is extremely important to alleviate the patient of the pain. And for moderate pain, what the doctors do is give NSAIDs, which are commonly known, whether it's diclofenac or it is etocoxib or whether it is indomethacin or whatever have you, plus the paracetamol, which is used, mind you, almost in 69% of the healthcare by the healthcare physicians. And paracetamol plus diclofenac, which is widely used globally, is used by almost 48% of the healthcare physicians. And this is what is important. That is what is the burden of this pain in the normal management of patients. Next, please. But when we use these NSAIDs, there are obviously some limitations of NSAIDs. And these all of us know. Not only there are limitations which are acutely there, something like the drug reactions which we find in day-to-day medication. We have severe gastritis, we have some severe allergic phenomena, or sometimes even gastrointestinal disturbance which is it. Sometimes in very, very rare cases, but acutely we can see something like blood coming out of the GI tract, and that can cause very bad complications. So the duration of NSAID use and the dosage administered decide the severity of complication. And this is what is very, very important. The doctors have to be very careful using these NSAIDs, whatever it could be piroxicam also. And we have seen severe problems having GI bleed, which is seen in many of the patients. And there is an increase in the risk of GI complications in almost 55 to 75% of healthy subjects. And all of us doctors, especially the orthopedic surgeons, have seen this day in and day out. And that's what is worrisome and which we have to be careful about. The use of NSAIDs is inappropriate in patients with previous history of GI events like bleeding and ulceration. And this is extremely important. That's why the past history and the previous history, where the patient has had problem with the NSAIDs, is very important to find out. At the same time, there are certain comorbid problems like certain hepatorenal problem, kidney or hepatic problem, which we have to be extremely careful, especially those patients also having a cardiovascular disease or some kind of intervention which is done in the cardiac cases are also, we have to be very, very careful when we are using these NSAIDs. Even a short-term use of NSAIDs less than 90 days increases the risk of coronary artery disease. And this is extremely important. So it's a multi-system problem that we can have with NSAIDs, which we have to be careful about. And all these problems which are seen in patients which are susceptible, elderly, and in which these are used sometimes inadvertently, sometimes the patient themselves take, because some of these medicines are over the counter available, and patients tend to take them, especially in India. They take these medicines, supposing we give them 10 days also, but they keep on taking these medicines and cause problems afterwards. Next, please. So now we are concentrating more on nutraceuticals for pain relief, because these are compounds or materials that can function as nutrition as well as they exert a potential therapeutic effect, including relief of pain. So these are very, very important drugs that we are looking into, and we are thinking that they could be alternative, causing less of side effects, less of drug reactions, and could be used for a long term. So emerging evidence indicates nutraceuticals may represent promising alternative for the relief of pain. And this is extremely important. And we have in India all throughout, in fact, Ayurveda also for last 5,000 years, we have been advocating herbal medicines. Curcumin has been very famous in giving. We have been using Boswellia, and all these medicines are there of Indian origin, most of them. Though we have not taken patent for all these, they are emerging as extremely important anti-inflammatory agent, and they have to be used as much as possible. And there is a lot of research which have gone into using these medicines for pain relief. And we must concentrate on that. And that is what the whole webinar today are going to be discussing. Next, please. So we have this devil's claw, which is a slow-acting anti-rheumatic or anti-inflammatory drug. We can call it drug or a nutraceutical, which is very important. And that is what we are going to learn from learned Professor Dr. Sigrun Cherubesic from Switzerland, University of Freiburg. And I welcome Doctor to give her talk on devil's claw, which is going to be really taking India by storm. And I thank Dr. Reddy's laboratory for getting it here. And Reddy's, as you know, have been pioneering in lots of newer and newer medicines and newer drugs, which have helped lakhs and lakhs of people across India. And I thank Dr. Reddy's for getting into this pain management by using very, very novel devil's claw. Over to you, Professor Sigrun.
Thank you very much. Dear colleagues, I'm very happy to give an overview on devil's claw, which is a slow-acting anti-rheumatic drug. 11. Hello? So the slide before was on the classical anti-rheumatic treatment, which includes cortisone, basic anti-rheumatics and NSAIDs, as we have heard, and biologicals and analgesics. So these are associated with adverse events. Cortisone causes hypertension, diabetes, immunosuppression. Basic anti-rheumatics and NSAIDs damage the gastric mucosa, the liver, the bone marrow. The biologicals cause immunosuppression, liver damage, and adverse events to be defined because they are not so long on the market. And analgesic, like paracetamol, cause liver damage, which make liver transplantation necessary in some cases. 13. Next slide, please. The next slide, please. So the herbal biologicals are a new treatment perspective because they have an advantage over synthetics because of their broader mechanism of action. Next. Here you see the mechanism of action of the herbal biologicals. They inhibit not only COX-1 and or COX-2. Some are COX-1 and COX-2 inhibitors like nettle or ginger, but devil's claw is a selective COX-2 inhibitor. They inhibit more or less lipoxygenase. They inhibit cytokine production, hyaluronidase and or elastase, and they do have an antioxidative effect. Next. So in osteoarthritis, we do have two processes. We do have inflammation caused by prostaglandins and leukotrienes, and we have cartilage destruction caused by cytokines, for example, tumor necrosis factor alpha, free radicals, and interleukin-1 beta is another cytokine. And we do have cartilage destruction via the enzymes elastase and hyaluronidase. Next. So osteoarthritis and rheumatoid arthritis have something in common because they both affect the joints and the muscles. But osteoarthritis, the most common form of arthritis, especially in older age, can be treated with phytomedicines as first choice, not rheumatoid arthritis, which is an autoimmune disease where you can offer phytomedicines only concomitantly, not as sole treatment. Next slide, please. Habergophytum grows in Southwest Africa. Next. there are two species, Hapagophytum procumbens and Hapagophytum zaiheri, which both are acknowledged by the European Medicines Agency as a crude drug of Hapagophytum. Next. Hapagophytum zaiheri is a little less potent as Hapagophytum procumbens. Here you see a research in rats, the carrageenan-induced rat oedema test, and you see that Hapagophytum zaiheri, the white line, is less potent than Hapagophytum procumbens, the red line. Control did not show efficacy. Next slide, please. The fruits, once in the paws or in the fur of animals, that is very painful for the animals, and they dance like a devil. For that reason, the plant has got the name devil's claw. Next. At the University of Munich, one tried to cultivate devil's claw. This is possible, but the plant, the roots, do not contain as much active principle as if they grow wild. So still today, it's wild collected and not cultivated for that reason, because it has less active principle. Next slide, please. You harvest the secondary roots of devil's claw, which contain the co-active ingredients hapagoside, hapagite, and procumbite. Next slide. This is the devil's claw broad spectrum targets. Devil's claw inhibits tumor necrosis factor alpha, interleukin-1 beta, interleukin-6, and interleukin-8, inhibits the metalloproteinases, inhibits selectively COX-2, lipoxygenase, elastase, and has an antioxidative effect. Next slide, please. This is the mice writhing test, where you inject acetic acid into the skin, abdominal skin, and the mice will scrap. And once you inject an anti-inflammatory drug, here the control was aspirin, or if you inject devil's claw extract or its leading compound hapagoside, you see that Hapagophytum extract has a dose-dependent effect, and also the leading compound, but that is seen with almost all plants, that if you take one ingredient out of the extract, it is not so potent as the extract, because there are other co-active ingredients in the extract. Next slide, please. Hapagophytum extract has no spasmolytic effect and no central analgesic effect. Next. This is taken from the thesis of my daughter Julia, who investigated Hapagophytum extract in rabbits with experimental osteoarthritis. This was a special extract containing 14% of hapagoside, so it was possible to give higher dose. Rabbits got either Hapagophytum extract or normal food over 6 months. And then the rabbits were killed and the cartilage acerbated for cryopreservation and RNA preservation. Next slide, please. Stainings with hematoxylin, safranin, and elastica showed a trend towards cartilage regeneration and an increase in elastic and collagen fibers. So this was a very strong model of osteoarthritis, and therefore the effect was we showed a trend of cartilage regeneration, which is really something. And this was supported by the next, please, by the fact that real-time PCR, that's polymerase chain reaction, showed a 2 to 5-fold increase in expression of TIM2. TIM2 is tissue inhibitor of metalloproteinase 2, which inhibits cartilage destruction via metalloproteinase 2. So this also proves that Hapagophytum extract has a cartilage preventive effect, further supported, next slide please, by the excretion of crosslinks or crosslabs. These are metabolites that are excreted via the urine when cartilage is destroyed. And you see, after 6 months, there was a significant reduction in the excretion of crosslinks in the Hapagophytum treated animals. Next slide. So when I started to investigate devil's claw, I investigated the 10 crude drugs which were available at that time in Germany for preparing a tea of the crude drug. And as you can see, the crude drug contains 1.1% of hapagoside, which is the minimum. Otherwise, the drug is not allowed to be sold in a pharmacy. So that is the minimum requirement, 1.1%, up to 3.6% of hapagoside in the crude drug. Next slide, please. Next. And this shows you that the daily dosage in the tea prepared from 4.5 gram crude drugs, according to the monograph, the German monograph, and also the EMA monograph, varies between 50 milligram in the tea up to 163 milligram. So the daily dosage of hapagoside in extract should be at least 50 milligram up to 160 milligram per day. Next slide, please. I wanted to know if the hapagoside is destroyed by stomach juice. So I prepared artificial gastric juice according to the American Herbal Pharmacopoeia and was able to show that hapagoside was not destroyed in the gastric juice. Here you see the control in water, which was also not destroyed. Next slide, please. This slide shows you stability in intestinal fluid. I also prepared it according to the American Pharmacopoeia. And you see that the hapagoside, the leading compound, is not destroyed during 6 hours from intestinal fluid. This is a good thing that you can use it orally. Next slide, please. Also important to know is hapagoside absorbed into the blood? Can it reach the joints? And indeed it can. We investigated plasma and blood and were able to show that there was a dose-dependent increase in the hapagoside level in the blood. Next slide, please. When I started my research, I started it because of myself, because I was at that time already a chronic pain sufferer, and I was on NSAIDs, took every day diclofenac, and I knew if I take that for years, I would suffer from adverse events. And therefore, I wanted to know about the potential, the analgesic and anti-inflammatory potential of devil's claw. There were 36 medications on the market, and I investigated all of them for the hapagoside content and found a daily dose of 0.2 milligram in the daily dose of a preparation up to 50 milligram. There was no other medication available offering more. And I knew from the study before that the daily dose can be up to 150 milligram. But 50 milligram was the maximum I was able to get. So I decided to do a clinical study with that medication. Next slide, please. Next slide, please. Thank you. So I planned a confirmatory study over 4 weeks. I included chronic low back pain patients with acute exacerbations and offered them either 50 milligram of hypochlorite in the extract dose per day or a placebo. Next slide. I had worked 15 years before I entered phytomedicine. I had worked in the field of acute pain. So I adopted the consumption of rescue tramadol as main primary outcome measure. It was expected that the tramadol consumption during hypercophytum treatment was less than half of that during placebo therapy. At that time, I expected that the chronic pain patients take as much pain rescue medication as much they need. But next slide, please. This is not the case. Here you see patient days patients suffer from moderate and severe pain and did not take rescue medication. On the left part of the slide is the patient days with rescue medication. You see most patients did not take the rescue medication, although they could. Next slide, please. So I failed the primary outcome measure. So we did not confirm the hypothesis that patients require less tramadol during treatment with the extract. This slide shows you the median tramadol consumption per day. You see it did not differ in patients suffering from severe pain, which a verbal rating score of 4, to moderate pain, verbal rating score of 2 to 3. There was no difference. And you would have expected that patients take more tramadol if they are more in pain. So the study, although planned confirmatory, is in the end only exploratory. That means it shows you a trend of effectiveness. Next slide, please. But what we found out, when calculating the numbers of pain-free patients in the 4th week of treatment, there were more patients pain-free, 20%, in contrast to 1% in the patients getting placebo. Next slide, please. So I planned another confirmatory study investigating 2 doses of hypochlorite in the daily dosage, 50 milligram and 100 milligram. It was also a placebo-controlled study in the same population, chronic low back pain sufferers with acute exacerbations. Next slide, please. And here we were able to show that the number of pain-free patients increased as we expected. There were 10 patients pain-free in the high-dose group compared to 6 in the low-dose group, and this was significantly better than the 3 in the placebo group. Next slide, please. At that time, there was a randomized double-blind study done in France over 16 weeks, including patients with knee and hip osteoarthritis. In France, they offered powder with 60 milligrams hapagoside in the daily dosage. The control patients received an NSAID, diacerein, which is an ingredient of rhubarb, and therefore not wondering that adverse event is diarrhea. So the main criterion was non-inferiority, that the NSAID is, that the hapagophyton powder is non-inferior to diacerein. Next slide, please. And this is shown here. Spontaneous pain over 4, 8, and after 4, 8, and 16 weeks did not differ between the groups. Next slide, please. And also not the functional index, the Lukasner index did not differ. Next slide, please. And although we have 2 confirmatory studies proving that aqueous extract with 50 or 100 milligrams hapagoside per day in chronic low back pain patients, and powder with 60 milligrams of hapagoside per day in osteoarthritis patients. At that time, there were 2 confirmatory studies available that showed that ethanolic extract with 30 milligrams of hapagoside per day was not effective at all. So we have 2 confirmatory studies showing effectiveness with a higher doses. Next slide, please. Here I show you that I found out that this ethanolic extract that was investigated in the 2 confirmatory studies was not completely extracted. It contained 12 milligrams of hapagoside, although when I calculated the crude drug 5:1 drug extract ratio, if it contains 1% of hapagoside, it should contain 24 milligrams, 1 tablet. So with the 12 milligram 2 tablets offered 24 milligram of hapagoside, which is not enough to treat patient pain. So with the aqueous extract, I investigated in the most of the studies. I found 10 milligram in the tablet, and if I recalculated, if it's 1% hapagoside in the crude drug, 2.5 to 1. So the daily dosage offered 60 milligrams of hapagoside, which is almost 3 times that dose. Next slide, please. And I investigated also other ethanolic extracts. If you look at the line C, in that preparation, I found 5.7 milligram of hapagoside in the tablet, but should have contained 12 milligram. So you have to know the hapagoside content of your medication. Next slide, please. So I wonder why the EMA, that is the European Medicines Agency, in their monograph, they classified hapagophytum as traditional use medication, despite the fact that there are 2 confirmatory studies done that prove that it's effective, and that they also did not include standardization on hapagoside. They recommend 4.5 gram crude drug, which is not enough, certainly, to treat stronger pain. Because you know, if you have 1% drug, it offers only 50 milligram of crude drug of hapagoside. So next slide, please. So I then wanted to know if there is a difference in response between low back pain sufferers and knee pain sufferers and hip pain sufferers. So we had 3 centers and investigated the extract containing 60 milligram of hypocresate per day. Next slide, please. Next. Here you see that there was no difference in response if patients suffered from back pain or knee pain or hip pain. This was an important information. Next slide, please. Then I did a study over 1 year. I wanted to know the improvement of pain over 1 year. And you see that it takes 2 to 3 months. The visits were done every 6 weeks. It takes about 3 to 4 months until the full effect is achieved. And but then it is maintained. This was important information. Next slide, please. You know, observational studies, if you consider dropout in the analysis, which is last value carried forward, is then intention to treat analysis. If you use good statistics, repeated measurement ANOVA, plus multivariate analysis considering possible confounders, then you may get good internal validity, and the study provides useful data for a future definitive study that proves the efficacy. And I have done so in all my studies. Next slide, please. So the Canadian orthopedic associations, they recommend to use, to calculate the responders independent which medication is used, because you can then compare the different medications. So we also used that criterion, which is a 50% improvement relative to baseline, or a 20% improvement in absolute value. Then if patients fulfill this, they are responders. And they may be also responders if they improve at least 20% relative to baseline and have a 10% improvement in the absolute values. Then these are also responders, and all others that do not fulfill these criteria, they are non-responders. Next slide, please. So we calculated from that study the number of responders. And again, you see it takes 12 to 18 weeks until full effect is achieved. And this is already mentioned in the German monograph from the early 80s, that patients have to take Hypocrophytum extract at least for 3 to 4 months before they decide whether it's effective or not. So after that, the number of responders remains stable. Next slide, please. And because one study, this may be by accident, may have been by accident that I achieved this, I did another study over 1 year and was able to show that you have 60% responders in the course of treatment. And this is really something. And it is certainly in the range comparing with other NSAIDs. Next slide, please. Then I did a randomized double-blind study over 6 weeks comparing the aqueous extract with 60 milligram of hypocresate in the daily dosage. I compared it to rofecoxib, 12.5 milligram, which at that time was considered as safe. Otherwise, I had not done that study. Later, it was withdrawn from the market. Next slide, please. Here you see the number of pain-free patients in week per week, and the number of pain-free patients increased in the Hapagophytum group from week to week. And also in the rofecoxib group, it decreased towards the end, but we had more dropouts in the rofecoxib group, so that this is not a true effect. Next slide, please. I included in all my studies patients that suffered from acute exacerbations of more than 90 days. You see here the number of patients. This is from my confirmatory study with the two doses. Next slide. And this population is very difficult to treat. So bed rest will be not effective. Paracetamol and NSAIDs have only very little effect in these patients. Next slide. And also manipulation, back school, heat and cold treatment, exercise, facet injection, and traction have only little effect. This is from the International Association for the Study of Pain. They brought together all the studies and like the Cochrane group is doing, and gave a final statement on that, that if chronic non-specific low back pain with its acute exacerbation is longer than 90 days, it's very difficult to treat. And as you have seen from my studies, there is a effect, an analgesic effect, and also a functional effect. Because I use the Aarhus low back pain scale, which includes also back function, for example, or I included the WOMAC, which also includes function in the back and hip patients. I used actually in my studies a battery of many instruments, and I have seen an effectiveness in all of them, but I presented you now only the ones which are most impressive. So next slide, please. Today, there are 3 systematic reviews available. They included up to 11 observational studies, classifying them according to their quality, 2 open control studies, and 10 randomized double-blind studies, 8 versus placebo and 2 versus NSAIDs. These studies were done with powder or extract containing different doses of harpagoside, 30, 50, 60, and 100 milligram of harpagoside, but effectiveness has been shown only with preparations that had more than 50 milligram harpagoside in the daily dosage. And we do have 2 confirmatory studies, as I said, that prove efficacy. Next slide, please. Hapagophytum is well tolerated by the patients. Contraindication is gastric and duodenal ulcers. Why? The hapagoside is a bitter principle, and these patients would deteriorate if you give them the bitter principle if they have a fluoride ulcer. So that is the only contraindication. There's no special warnings. Next slide, please. There's no worry about interactions. Hapagoside and hapagide have been tested. They did not inhibit cytochrome P453A4. And I did with my daughter, Julia, a systematic review on all studies. We looked for the adverse events, and 138 patients out of 4,274 patients suffered from adverse events, minor adverse events, which is about 3%, which is in the range of placebo. Next slide, please. In pregnancy and lactation, hapagliflozin extract has not been systematically investigated. For that reason, the EMA monograph exclude pregnant and lactating women. Next slide. Of course, chronic pain treatment should be treated multidisciplinary and should integrate also psychological and social factors and should at any rate be individual. This increases treatment success, but it makes sense from the data I presented you to include devil's claw extract in the treatment of chronic pain, for non-specific low back pain, for hip pain, or for knee pain, according to arthrosis. So this is my final slide, and I thank you very much for listening, and I hope you have many questions now. Thank you.
Thank you very much, Professor Sigrun, for your wonderful and lucid talk. It has really made clear lots of questions that would have been with the audience. And there is no doubt that alternative medicines are going to stay. And we have got traditional medicines which are available with the boswellia, the curcumin, we have glucosamine, we have chondroitin, and all these have been extremely helpful, and we have been using it for such a long time. Now, there are certain questions that have come from the viewers, if you wish to answer them.
Yes.
So first of all, the main concern about these people, because devil's claw is not, it's quite alien to us. Where is it available? First of all, I mean, the basic ingredient, which part of the world is available? Is it available?
Where it comes from, devil's claw, it comes from South Africa. It's still widely collected.
So is that the only place that it is available from?
As far as I know, yes.
Okay, and is it possible to make it here, native in India too? Because we have quite...
yes, I have no doubt that it is possible to settle it, but it has to grow wild.
Oh, okay. So wild is very important. So they actually go in the woods to collect it, is it?
Yes, you know, they teach the local people how to harvest the root, not to destroy the plant.
So that means that there is a limited supply of this, right?
Yes, yes.
So after certain days, we will be not getting this.
You know, they look very careful that people are not collecting the roots properly. So this is controlled, and to have enough supply of the root for the future.
Yeah.
But you cannot water it. If you water it, so the plant will produce less active principle.
That's right. That's right. So you talked about the side effects mainly to the GI tract of this, whether if it is used for chronic time or long time, but you haven't really mentioned about renal or cardiovascular side effects, if there are any. Did you find any?
No, it's not reported in the literature. Not at all. The only thing I know from my outpatient clinic is that if patients have a sensitive stomach, they cannot take it without a meal. So they have to take it together with the meal. And this is possible because the hapagliflozin will not be destroyed by the gastric juice, as I showed you.
Okay, so there is one other question also from the audience, that can it be used as a standalone medication, or does it need to be standalone, single devil's claw? Can that be used as a single medicine, or you need to add with paracetamol or diclofenac or something like that?
You know, I try with my patients to offer it as sole medication.
Yeah.
But if pain does not decrease enough, then I combine it with curcumin, for example, or even some request. Instead of NSAIDs, I prefer tramadol, to combine it with tramadol.
So is it wise to say that in the beginning, just to get the confidence of the patient, because it's going to take some time before this medicine could act, combine it with tramadol to start with, and then later on?
Yes, this makes sense. This makes sense.
And if you have devil's claw along with curcumin, is that a good idea?
Yes, of course, of course.
So
you know, what I wanted to add is that the chronic pain sufferers, they are used to their pain, and they are very patient. So it depends on the individual case if you give it together with tramadol, or if you give it and wait until the patient tells you, now I'm happy with that.
Okay, there is one interesting question that you have been promoting this in the developing countries, but is it also available in the developed market like a USA or Europe? Is it available, and is it well respected there?
I know that it is available in the States. In Israel, there is a preparation which has 80 milligram of hapagoside in the daily dosage, which is better than 50 milligram. So, you know, I wanted to do a confirmatory study with 100 milligram, a second one, but in Germany, they withdrew it from reimbursement, so that today the market is very small with devil's claw.
Okay, fine. One other very interesting question is that you spoke about it being used in rheumatoid arthritis.
Yes.
So would you like to start treatment right in the beginning of rheumatoid, or something which is chronic? Where do you
Yes, I suggest at any rate to offer the rheumatoid arthritis patients also devil's claw to save on other, for example, on NSAIDs or paracetamol, which have more severe adverse events.
So there is so much of a research being done as anti-rheumatic medication or anti-rheumatoid medication, but do you think that this can really replace all of them in future?
You know, the potency of devil's claw is not as strong as that of the synthetic biologicals, for example. So you only can save in rheumatoid arthritis patients, you can only save. I never treat rheumatoid arthritis patients alone. I always contact a rheumatologist, and we treat together. We decide together what we recommend the patient.
Yeah, because in rheumatoid, it is always dictum that strike it early and strike it hard. So we got to really, right in the beginning, rheumatoid, we have to start treatment very rigorously and vigorously to see that the rheumatoid is not progressed. But if you are going to wait for 2 months, 3 months, 4 months with devil's claw treatment, I'm afraid there will be a cartilage damage which cannot.
Yes. So therefore you can only give it concomitantly, as I said. You have to give the devil's claw concomitantly to the other medications, the rheumatologist. And then in the course of treatment, you can try to reduce the NSAIDs. Mostly they give NSAIDs or cortisone, and to reduce these doses. And if it remains stable, the better.
Yeah, so there are certain questions that how is it as compared to other NSAIDs like diclofenac, etocoxib, and the ones that we are using here. So I think it would be a good idea to have a randomized control trial with having a similar number of patients taking devil's claw and similar number of patients taking other NSAIDs. And I think that is a good idea, and which we do that along with you in India. Because whatever studies that you have done probably are with paracetamol, placebo, and rofecoxib, which doesn't hold true now because the rofecoxib has been withdrawn already.
Yes, yes.
So do you think that it would be a good idea to do those trials here, clinical trials, or
Yes, of
post-marketing
course,
survey here? And so we
Yeah,
can do it together with you, with your
yeah,
basic research, and we could probably see in number of patients, maybe 50, 100, 200 patients, so that we
yeah,
can
okay,
actually compare and see how effective it is.
okay.
And we should also try in low back pain, osteoarthritis as well.
Yes, yes,
Because as orthopedic surgeons, besides rheumatoid arthritis, we also get many patients having low back pain or even cervical pain. We have osteoarthritis, and this is really a big burden on us. So I think
yes.
that would be a good idea to compare only giving devil's claw as a standalone single medicine or a drug, and also the other medication.
Okay, yes.
And does this qualify as a drug or a nutraceutical?
I did not understand the question.
Devil's claw, does it qualify as a drug or does it qualify as a nutraceutical?
It is actually, it's classified among the nutraceuticals.
Yeah, because there are certain different rules, as you are aware of, for drugs and for nutraceuticals, because nutraceuticals could be available off the counter. Whereas
But you know, you can use the EMA monograph, the monograph of the European Medicines Agency, as a proof that it's a nutraceutical.
so is it a prescription drug or it can be taken by
No.
the patients themselves?
No, it's no prescription drug.
Okay.
Patients have to buy it themselves.
There is one interesting question from Dr. Udit Sakhuja, that which kind of patients of rheumatoid arthritis are these? Whether you would prefer the early stage of rheumatoid arthritis to be treated by devil's claw or later on in chronic stage?
I would start immediately.
Okay. And what is the ideal dosage that you would recommend of this?
I would suggest to start with extract dose with 100 milligram and even to increase but there's no information on 200 milligram. But it's you know, if we do a study, we should use double the dose to see whether we can have a faster onset. And you know, it may even be faster, the onset, if patients consume 100 milligrams of harpagoside per day, because the information before was taken from my study where I offered 60 milligrams of harpagoside per day.
Okay.
So it may be faster.
So your adverse reaction in especially those patients having duodenal or gastric ulcer, was that immediate or over a period of time?
You know, if I know that the patient has an ulcer, I would not offer him devil's claw. So these are excluded.
Okay. Does your dose depends on the severity of pain, or is the same dose that you will be giving irrespective of whether it is acute or chronic or severe pain or mild pain? Is it the same dose you will be giving?
Yeah. Because I cannot offer more, because in Germany the 60 milligram is in 6 tablets. So if the patient takes 6 tablets, it's impossible to consume more. For that reason, a new preparation should have come on the market, a forte medication, which had 100 milligrams. So with this, which had 100 milligram in 6 tablets, again, it's not possible to increase the number of tablets. So I wonder what the 100 milligram of harpagoside in your Indian medication is in how many tablets?
Okay, fine. So again, there are plenty of questions on the adverse effect of drug, which you have said that it is relatively safe, but people want to know in case of patients having multiple other problems, comorbid problems like diabetes, hypertension, or some other comorbidity, can they safely take this if they have a renal problem?
Yes, yes, yes. There are no interactions to be expected, so it can safely be taken in these patients.
So these trials that we had done were in Switzerland or any other place?
No, I've done these studies all in Germany.
In Germany. Okay, fine.
All studies were done in Germany.
And how is it transported, this Devil's Claw? Is it transported
Yes.
in liquid form or in powder form to the manufacturing companies?
Okay.
Okay, how do you transport this Devil's Claw to the company which is manufacturing this nutraceutical?
No, these are tablets to swallow.
No, that is right. But how do you from
this
South Africa, how is it transported to Germany? The Devil's Claw, the plant, how is it transported?
Yeah. I think the producer company, they get the roots, the dried roots, and they prepare. It's Finselberg is, for example, is one of the producers, and they prepare the extract in Germany, in Koblenz.
So the extract is prepared in Germany or in South Africa?
No, in Germany.
Okay, fine. There are certain questions about pregnancy and lactating mother, which you have already given in the slides, that it cannot be used in pregnancy and lactating women. And there is no trial which has been done. So people should refrain it to be used. And surprisingly, we see that in pregnant women, if she is already suffering from rheumatoid, the nature reduces rheumatoid arthritis, okay, during pregnancy. So there is some hormonal effect, fortunately, during pregnancy, which actually halts the progression of rheumatoid. So that is something which helps.
Now, so, you know, there are no studies proving safety. For that reason, if you give it to a pregnant, you do not know whether it's safe for the baby. So it has not been investigated.
Okay, other question is that in case if the patient is on other drugs for diabetes, hypertension, or for any other problem, is there a drug interaction which has been studied?
No, it has not been studied and it has not been observed. There are no, if you look in the web, there is no report on an interaction with Devil's Claw.
No, but if it has not been studied, how would you know it is no interaction?
Yeah, because, you know, it's widely used. It's widely used over so many years, you know, that if there would have been interaction, I think it would have come up.
So just tell me, how many years has it been used? Or is
it came to Germany in the 50s, 1950.
Oh, so it has been used extensively since then?
Yes, and widely used.
Okay. Is the use of this nutraceutical in progression, is it increasing day by day or is it the same, the usage?
In Germany, it is no longer increasing. It was increasing tremendously, but the synthetic industry, they made so much pressure on the politicians that they excluded the Devil's Claw from reimbursement or all herbal medicines.
That's the situation here also in India.
Yeah.
Okay, so there is one question which is also interesting. What's the half-life of Devil's Claw?
The half-life has not been calculated.
Okay, so how would you know the duration of action then?
Just by observation.
Okay, what is the longest duration that this medication could be given to a person, to one single person?
There is no, according to the European Medicines Agency, there is no restriction. They can take it over years.
So is there any long-term problems which you have seen? Because your medication you have been given in the studies for maximum 3 months of time. That's what I believe from your talk.
Yes, I know many patients who took it or take it still over years, and they don't have any problems at all.
Okay.
So I started to take it in 1998
Yourself.
myself, and I take it since then, and it's
Okay, fine.
I'm really happy with it.
That's 22 years.
Because of my chronic pain, low back pain problem.
But that's
I
because-
had Scheuermann's disease when I was young.
Uh-huh.
And people suffering from the Scheuermann who had that in the youth, they have a lot of problems their whole life.
That makes two of us. We have something common. Even I have the same problem.
Yeah.
So I think Devil's Claw should help me, it looks like.
Yeah.
So,
I'm sure.
So probably I think this Devil's Claw must have been coming free to you. That's why you have been using it for 22 years. Maybe in India it is expensive.
Yeah.
I don't know the price. So that's what I was wanting to know from some person from Dr. Reddy's, Aditi, if she can throw a light. Yeah, she tells me that it is 39 per tablet. But is it only one single tablet that people have to take? Once a day. Okay. So is there a particular time that you would recommend in the morning or evening, before food? After food?
No, I tell my patients they shall take it every day the same time.
Morning.
It depends. Some prefer morning, some prefer evening. So it has to be the same time.
Okay. And one very interesting topic which probably will interest the doctors, and I think all the doctors come out with this question, is that whether there is any interaction with alcohol.
No, it's not. There's no study showing that it has interaction with alcohol, and it's not likely.
It's not likely. Whether with wine, with beer, with no, nothing.
If you consume alcohol in an amount that is not damaging your body, so it would not interact.
So let me ask you a personal question. You have been taking Devil's Claw for 22 years now, and have you been drinking beer? The Germans are famous.
I do not take it together with alcohol.
But that means you take tablets in the morning and beer in the night. Is that so? Okay, so I take it that it doesn't have a significant interaction with alcohol, and that's a good news for us and for our patients. Anything else you would like to tell us? Some word of caution or whatever?
Oh, no, I think it's, I said everything. So if there are no questions,
yeah. So,
I myself am very happy that I have Devil's Claw
because okay, sorry, go ahead.
Yeah, because I have acute attacks from time to time when I combine it with willow bark extract. Willow bark extract is for acute pain.
Oh, so we don't have that in India, so we don't have to worry about it.
Yeah. So, but I do not need any other medications for my back since I take that.
Oh, okay. So now
only herbal
Dr.
medicines.
Professor Segrun, I must compliment you for the fantastic skin texture that you have and such young look that you have, your face. I think, shall I give the credit to Devil's Claw for that?
I don't know.
Or the beer. Okay, I think there's a good news for Indian audience and the viewers which are there. This tablet in India is available as Delcinize from Reddy's. It is already available and it costs only 39 rupees per tablet, and that is only once a day. So that's very cost effective, and it could be easily given. So it contains about 250 milligrams of Devil's Claw. It also has curcumin as an adjuvant. So that's a good news too, as you said, that probably with curcumin, it would help as an adjuvant to help increasing the efficacy.
Okay.
Yeah, so I think
Yes,
that's
I support that.
And with that, I think I should invite you to come to India, and we should have much more person-to-person discussion on this. And you being taking this Devil's Claw for such a long time, 22 years, is an ideal candidate to convince people that this is a good medicine or a nutraceutical. Isn't that true? And we should have a collaborative some studies on the market research to compare it with other medication which are available.
Yes.
We should actually do that and write your 101st paper.
Okay.
Yeah,
Wonderful.
We should request Dr. Reddy's to help us to write some research papers on that.
Okay, no problem.
That would be something good. And you can make a visit to India, see
Yes.
Taj Mahal, and go to Srinagar also, Kashmir. It is safer than what it was in the past.
Yes.
Yeah, so thank you very much, Professor Sigurd, for your fantastic lecture today. We have been really enlightened, and we are very happy that you came today and discussed this thing, and you interacted very well. There are lots of questions. There are more than 1,500 people who have logged in, and that's a small number for Indian population. And let me tell you.
Thank you. Thank you.
So I think all of them have been really happy with your interaction and your talk. They are convinced that this medicine could be tried in so many patients that we have of rheumatoid arthritis and also musculoskeletal pain. And I'm sure all those patients will be benefited. And in these COVID times, which are pandemic, and in India also, it is very, very bad situation. I think this pain management, nutraceutical, which are alternative medicines, traditional medicines, which are going to be helpful in the future.
Thank you.
Thank you. God bless you. And all the best. And have a good day and stay safe. And I wish you a healthy future. Thank you.
Thank you, sir. Thank you, sir. Thank you so much. Thank you, Professor, for brilliant insights regarding Devil's Claw. I definitely see that as a definite pain alternative medications for pain relief, and all the best for the future. Sir, your suggestions will definitely be taken by DRL to take ahead few studies with you and Professor. And thank you, sir, for your time. Thank you for your valuable support, sir. Thank you so much.
Thank you, Dr. Shwetal, and thank you, Dr. Reddy's laboratory, for getting this together and enlightening so many good the viewers across. And I hope that you record this and spread it to other people too. Thank you.
Thank you.
God bless you and good day.
Thank you.